Not contracting an infectious disease in the first place is best. But if you are infected, then you've got to find a way to deal with it. Preventing and treating infectious diseases, tonight on Call with the Prairie Doc, celebrating our 20th season. Hello, I'm tonight's Prairie Doc, Kelly Evans Hullinger. This is the 20th season of On Call with the Prairie Doc, providing truthful, tested, and timely medical information. Joining us tonight here in our studio on the South Dakota State University campus in Brookings is Dr. Jennifer Hsu of Sanford Infectious Disease and Travel Medicine Clinic. Welcome, Jennifer. Thanks for coming up tonight.
Thank you.
Yeah. So, an infectious disease physician. Tell us a little bit about your background and what kind of patients you see and problems you help with.
Sure. So, by background, I did residency training in internal medicine after medical school, and then infectious disease as a subspecialty of internal medicine. So that was an additional fellowship training, and I actually see a broad variety of patients in the hospital and in clinic. We take care of, in the hospital, a lot of pneumonia, bloodstream infections, skin and soft tissue, joint infections. On the outpatient, on the clinic side, we take care of those follow-up for patients who we've seen in the hospital and continue their care. And then we care for a variety of more chronic infectious diseases. We take care of folks living with hepatitis C infection, HIV infection, chronic lung infection. So it's really a great variety.
Great. We look forward to answering your questions about infectious diseases. Call 1-888-376-6225. Send an email to ask@prairiedoc.org or ask on our Prairie Doc Facebook page. Each night, we work to answer as many of your questions as possible given the time we have for the episode. We do sometimes receive more questions than we can cover in that time limit. We apologize if we do not get to your question, but we encourage you to ask early to give us the best chance to answer. And to encourage your questions earlier, those of you who ask a question during the first 20 minutes of tonight's program will be entered into a drawing for one of our Prairie Doc gift items. The winner will be announced at the end of this program. Your question will remain anonymous, but be sure to provide your name and contact information when you submit your questions so we can contact the winner. So, when it comes to infectious disease, a lot of what you do is prescribe antibiotics for people who have infections. But another big part of your job is trying to teach all of us how to not use antibiotics when antibiotics aren't appropriate. So we call this antibiotic stewardship. Tell us what that means and why it's important.
So I think everybody's familiar with the term steward, which really means just to care for a specific resource. And so this has really been a very important part of our job. I would say probably over the last 10 to 15 years, it's really risen in prominence as a part of infectious disease practice because people have recognized that antibiotics are a precious resource and that if I prescribe a blood pressure medication or a diabetes medication, I'm impacting one patient. But when I prescribe an antibiotic, I am potentially impacting a whole community in terms of, am I driving more resistance in bacterial infections? And so we know that by reducing antibiotic use and using antibiotics in a more targeted way, that we can reduce the risk of antibiotic resistance, which makes more antibiotics available for everybody to use when you need them.
Yeah. What are some common things that you see antibiotics prescribed for that maybe we shouldn't or should think harder about prescribing antibiotics for?
I think probably one of the most common things we see are antibiotics used for respiratory infections, particularly upper respiratory tract infections, which are oftentimes going to be caused by viruses that aren't going to be treated by antibiotics. And so some of that is being very careful to do our best to sort out when is it potentially a viral infection versus when is it a bacterial infection that will benefit from antibiotics. And we've had increasing data that have driven guidelines to help us make those decisions over the last several years. So I'd say respiratory tract infections, same thing, whether that's upper respiratory tract or lower respiratory tract, is how can we be really cautious about trying to not treat viral infections?
Yeah. Yeah, and sometimes it's difficult. I mean, I encounter this all the time. For example, if someone comes in with symptoms of sinusitis, very common, I tell them, I can't look at you or ask you any questions that help me know if this is a virus or bacteria. But guidelines in that case are based on duration of illness, which just kind of plays the statistics, right?
Right.
Yeah.
So statistically, those are going to be more likely viral infections. We know that if someone is getting beyond 7 to 10 days of symptoms, if they got better initially and now they're getting worse again, or if they have a high-risk condition that says they are at a higher risk for bacterial infection, those are times where we might think about antibiotics right off the bat. But sinusitis is a great example of where we can be better stewards of antibiotics. And then I would also emphasize, it's not just the decision to start antibiotics, but it's also the decision to stop antibiotics, because we have sort of historically treated things for 7 days, 10 days, 14 days. But in large part, those durations of therapy are anecdotal. And so infectious disease physicians and researchers have really been making a strong push to actually do clinical trials to say, do we need to treat something for 10 days, or could we treat for 5 and get similar outcomes?
Right.
And so the probably prime example of that is community-acquired pneumonia, where we now know that many people with community-acquired pneumonia will benefit from 5 days of treatment, and they don't need longer courses. And so then we can also reduce the collateral damage of bacterial resistance. We've reduced the risk of side effects from antibiotics because we know antibiotic toxicities are a common problem, and so we can avoid those if we can shorten courses.
Yeah, I think that's going to be probably a hard thing to change, because the other thing that includes is us having historically told our patients, you have to take till that bottle's gone, and maybe in 5 or 10 years those instructions might look a little different.
I think right now that dogma is really being challenged.
Yeah.
So what we don't want people to do is just to say, oh, I took my day of antibiotics, I'm going to stop now.
Right.
So we don't want that. We want it to be under the direction of a physician, but we're recognizing that dogma of taking your antibiotics till they're gone isn't necessarily the best approach, because people are getting unnecessarily long courses. And so I agree that I think over the next 5 to 10 years, we're going to continue to see more data coming out that will drive shorter durations of antibiotics.
Yeah, more to come. Well, we're getting some caller questions. Let's start with a caller from Esteline who wanted to know, what is sepsis? Usually an infectious disease question.
Usually an infectious disease question. So sepsis really is a description of the body's response to a severe infection. So when we have an infection, and it could be a whole variety of bacterial and viral and fungal infections, it doesn't necessitate a specific organism. It is really that really robust immune response to infection, where people get high heart rates and high fevers and low blood pressure. People become confused. They may have breathing difficulties. So sepsis is really that very robust immune response that can happen with a whole variety of infections.
So we talk about sepsis, and practically speaking, we talk about early introduction of antibiotics, but we should remember that sepsis isn't always a bacterial infection. Influenza or COVID-19 commonly causes sepsis, right?
Absolutely, absolutely. So we have to think about that. And oftentimes, because people are so sick with sepsis, we're going to treat them with antibiotics until we have an alternative answer. If we identify then it is influenza, that's another stewardship opportunity to say, well, antibiotics aren't going to work for that. Let's stop those.
Yeah, good. We have a great question from Lake Ponset. Is tuberculosis still present in South Dakota?
Oh, very good question. So tuberculosis is still present in South Dakota. In large part, it affects our folks who have immigrated from other countries around the world where there are higher rates of tuberculosis. We do see some tuberculosis affecting South Dakota residents who are living on Native American reservations. Definitely still present at low levels. It's not a common diagnosis in South Dakota. The State Department of Health, along with public health agencies around the country, have really made focused efforts to identify people at risk for tuberculosis and try to treat them before it becomes an active disease that's more contagious.
Yeah, and that is one disease where it requires a longer course of treatment, and we need to make sure people get all the way through it, because it's a tough bug to kill.
It is.
Yeah.
But even, talking about duration of therapy, there are actually several trials that have come out in the past couple of years that are shortening durations of tuberculosis treatment. So what used to maybe take 9 months to treat to prevent reactivation of tuberculosis, now the first line regimen is 4 months, and people are looking at even shorter durations than that.
Yeah,
so antibiotic stewardship
news.
even playing into tuberculosis.
Awesome. This is an interesting question. So this is a question saying, what determines if an infectious disease has potential to be a pandemic or not? So this is a term we've familiarized ourselves with in the last couple of years. What are some examples of diseases that were a pandemic versus examples that were not a pandemic? So can you tell us what pandemic means and what it takes for a disease to maybe cause that?
Sure. So we distinguish between endemic diseases, which are diseases that are happening at some low level in the community all the time. This would be respiratory viruses in most common years when we see a lot of adenovirus or enteroviruses. Those are endemic diseases. Epidemic then are outbreaks on a more regional scale, and then pandemic is affecting generally the whole world by the time it's spread to that. So diseases that are most prone to pandemics, they tend to be things that are transmitted easily, and so respiratory viruses, influenza, as we saw with COVID, the coronaviruses, particularly the SARS-CoV viruses, just because they're so easily transmitted person to person, and you can shed asymptomatically, which increases the risk that someone doesn't know they're sick and that they're potentially spreading. So respiratory viruses definitely rule that list of things that are at a higher risk of becoming a pandemic.
Yeah, requires high levels of transmissibility, which for most infectious diseases, those numbers would be much lower if you're comparing to something like COVID-19.
Right.
Yeah.
Right.
Okay, we have a caller from Sioux Falls who wants us to address staph infections. So what is staph? What types of infections does that bug usually cause, and what implications does that have? Yeah.
Sure. So Staphylococci or Staphylococcus is a group of a whole variety of bacteria, different bacteria. The one we're probably referring to most commonly is Staphylococcus aureus. It's the one that tends to make people sicker. So it's actually part of our normal flora. It lives on our skin all the time. If you cultured my skin, you would find it there. And so we get infection when something is out of balance. So we get a cut, we get a scrape, we have a surgery that it's introduced through a wound would be the most common route. And Staphylococcus aureus can actually cause a whole variety of infections. It can cause skin infections, it can cause abscesses and boils, it can cause bloodstream infections. It likes to cause infections on prosthetic materials, so heart valve replacements, prosthetic joints, things like that.
Yeah, it's an interesting bug because yes, it's everywhere, but it can cause really severe disease when it gets in the wrong place.
It can, and it can be really hard to get rid of. It can be a tough bacterium to treat sometimes.
Yeah. So Staph aureus, you mentioned. Take us to the next level. What is MRSA? Tell us what that means.
Sure. So MRSA, or MRSA, stands for methicillin-resistant Staphylococcus aureus, and so I think this is people hear about this all the time. So what that means is that the Staphylococcus aureus has become resistant to a specific antibiotic called methicillin. The rates in the U.S. used to be about 50-50, where about 50% of isolates were MRSA and about 50% weren't. That depends on where you live in the country, what that balance is now. In our region, we've actually seen declining rates of MRSA infection. So methicillin susceptible Staph aureus is now more common than MRSA. So I think the reason MRSA is scary is just because it's resistant to some of the antibiotics that we would commonly use to treat more susceptible Staph aureus infections. And so we have a more limited assortment of antibiotics to choose from.
Otherwise, it's the same staph bug.
Right.
Just have some of those antibiotics crossed off the list of things that you can use at your disposal.
Exactly.
Okay.
Yep.
We have an emailer who asked, why do you get shingles more than one time? And alludes to getting it after COVID. So some people never get shingles. Some people may get it more than one time. Talk to us about shingles and why it might present. in people
Sure,
like that?
sure. So shingles is caused by the chickenpox virus. It's caused by varicella. And so what happens if you were exposed to chickenpox typically at a younger age, the varicella virus can lie dormant in the nerve endings. And for reasons that we don't always know, reactivates. And that's actually what causes shingles, which is usually a really painful or itchy rash. For most people, it'll be a specific patch. It's a specific location on the body.
Right.
So people can get it more than once. We know it gives you a temporary boost in your immunity after you've had shingles, but that immunity wanes over time. And particularly after folks get over age 65, their bodies are less able to control viral infections. And so it's more common to have a shingles outbreak as you get older. So I'd pause on a tangent just to say, we have a great vaccine for shingles, a 2-dose vaccine series for folks who are over 50, the general population. And so I just strongly encourage people to consider getting vaccinated against shingles.
Yeah. Do you think that there is a period of risk after someone's had a different infection like COVID-19 that in theory they might be more susceptible to getting shingles?
Possibly. We know that other viruses they're able to modulate the immune system. And the way I think about it is if your body's off fighting one virus, that it may temporarily be less able to protect from a reactivation or an infection with another virus. And so it's possible that COVID could increase the risk of shingles.
Sure. Well, if you plan on traveling, especially to a foreign country, it may be a good idea to see a health specialist at a travel clinic about diseases, vaccinations, and overall health. Prairie Doc reporter Carter Schmidt spoke with an infectious disease specialist about this topic.
Dr. Jawad Nazir says going to a travel clinic is important before traveling to certain countries.
It depends, like where are you going? Because there are certain countries in the world, especially in Africa, South America, Southeast Asia, or other parts of the world where there are infections we usually don't see in this country. So, people living here are not immune and they are at very high risk to get those infections and even die from them.
One of those diseases is malaria.
More than 600,000 cases, every year. A lot of people die from it. In USA, we see about 2,000 cases of malaria, mostly in people who are coming back, from international travel. So there are infections worldwide outside USA, which many residents of this country are at risk to get, and not only to get, those can be life-threatening. So I think that's why it's important to consider seeing someone who is experienced in travel health or infectious disease, or even your healthcare provider.
Nazir says you should see a specialist at least a month before you travel. The main thing they look at are the purpose and duration of travel and the potential condition of your surroundings.
There are many reasons why we should consider that, we should see someone who is experienced in travel health, get appropriate advice, to get these vaccines, which can prevent some of those infections. Now, it's not just the vaccines, I think a travel health specialist can guide you on certain infections which can be treated by taking medications.
The most important vaccines include your routine or childhood vaccines, but others may be destination specific.
Which country are you going to? And I think based on that destination, your risk of getting certain infections are high. For example, yellow fever in certain countries. So they are recommended, to get yellow fever vaccination. Now, the yellow fever may also be required by some countries.
That's why early consultation with a specialist is crucial.
Some of these vaccinations may take time to get the optimal, protection for you.
Great information. So we still, if there's a lot of places you travel where you need to take malaria prophylaxis, which they talked about, what are some of the more common travel vaccines that you recommend, worldwide? I'm thinking yellow fever and some of those other ones.
Sure.
Yeah.
So I'd say some of the vaccines we recommend for most everybody would be hepatitis A, which is a viral infection that can be acquired through contaminated food. We talk about malaria prophylaxis, as Dr. Nazir said. So that is an oral medication. We don't have a vaccine against malaria. Yellow fever tends to affect countries around the equator. So we work on yellow fever vaccination for a lot of our travelers going to African countries or South American countries. And then really travel is oftentimes a really good opportunity to get adults up to speed on their routine vaccinations, because we think about vaccines with kids, but we don't always as adults. We're just not thinking about that. And so oftentimes it's an opportunity to make sure we're getting folks updated on their regular vaccines at the same time.
Tetanus shot.
Yep.
Great. We've got plenty more questions, so let's slog through some of those. We have a Sioux Falls man who was diagnosed with an ear infection in the 1960s during the Vietnam War. He was told initially that it was swimmer's ear and then later that it was jungle ear. He's still medicating for it today. Is this normal with an ear infection to be so common and have painful flare-ups?
That's
Can you comment on that?
Interesting question. I think that's probably very tailored to his exposure history and what has happened. You know, the thing we worry about when people are getting recurrent infections, whether it's an ear or a foot or a leg, is that was there an initial infection that caused scarring or somehow altered the normal defenses? And so either the ear doesn't drain like it should or there's scar tissue in there impacting it. And so oftentimes when people are having recurring infections like that, it's because there was an initial infection that somehow altered the mechanics of that space. A little harder probably to comment more specifically, but when we see recurrent infections, it's often because there is some structural issue.
Okay. We have a Sioux Falls woman hoping to know more about C. diff. And then we had a second caller who asked, are antibiotics the best treatment for C. diff? So what's C. diff? How do we get it? And then how do we treat it?
Yeah, great question. So C. diff is kind of shorthand for Clostridium difficile. So it's a bacterium that lives in our bowels in most people normally. And what happens is when you get antibiotics for another infection, you wipe out the good bacteria. You may wipe out some of the good yeast in our bowels as well, because we have a lot of normal flora that keep our bowel functioning. And when the antibiotics wipe out the good stuff, it allows that C. diff to take over and to start multiplying. And it can cause very severe diarrhea. Can cause abdominal cramping. I mean, people having numerous bowel movements a day. And so we typically do treat C. difficile with different antibiotics. The antibiotics we use for C. diff, they stay primarily in the bowel so that they don't really get absorbed at very high levels. So we get really high concentrations of antibiotics in the bowel. And for most people, that's successful. C. diff can be challenging to treat, though, and we definitely see people who have recurrences that we have to address other ways. And so that's been a really active area of interest, is just figuring out exactly what are all the interactions of our normal gut bacteria to figure out how can we treat other infections that then don't impact the normal flora quite as much.
And in fact, a treatment for recurrent C. diff is actually a stool transplant, right? Where you actually take sort of healthy gut flora from someone else and replace the sick person's.
Yes. So that's kind of a blunt tool. That's where we've got right now, is that in some institutions can do fecal transplants. There's really a push to move to more standardized products for that. So that averts some of the safety concerns about giving other infections with a stool transplant. So there are actually some really active research studies right now looking at more standardized microbiome products that can replace those good bacteria that are lost.
Yeah, interesting. We had a caller ask, would an infectious disease cause tingling in the legs? Can you think of an infectious disease that would cause that? It would be really low on the list of things that would cause that symptom, I think. But,
I would agree. I think most of the time if an infection would be causing some type of sensation changes, probably it's going to be a skin infection where the leg is going to be bright red, hot, you may have an open wound. There are going to be other things that go along with it. So I think it'd be pretty unlikely that an infection alone would just cause tingling.
Yeah, agreed. We have a man wondering if the doctors have ever looked at PubMed articles, NRF2. He takes a pill that activates NRF2 and wonders if it might have an impact on infectious disease. I'm lost.
That's
you got anything?
Very good question. I think I'm going to have to say I don't know to that one.
Okay, we may have to
look into that.
You're going to drive us to go learn something. Thank you. We have a woman wondering if we can talk about intertrigo infection.
Sure.
Okay.
So intertrigo is a common problem. Lots of people struggle with it. So essentially, it's a yeast infection in the folds of our body. So yeast like to live in warm, moist, dark places. And so underarms, the groin area, for women under the breasts can be problematic. And so there are several ways to address it. Typically, we start with just how can we get that area drier?
Yeah.
So, using drying materials, all cotton, avoiding really tight-fitting clothing can be a first step for a lot of people. And then beyond that, we have topical antifungals, powders, creams. Sometimes we do have to get to using oral medications if it's severe. And then we start to look about other things too. Does somebody have diabetes that isn't well controlled? Because high sugars could produce severe intertrigo. So we do try to make sure that there aren't other reasons why someone might be suffering from recurrent yeast infections.
Yeah, but a lot of that is learning how to get the skin to have more time dry.
Right.
Which is challenging sometimes.
Yeah, it can be.
We had an emailer who asked, why was there such an outbreak of RSV in adults last year? Which is an interesting question, and I think we've probably asked the same thing, because we don't usually test for RSV in adults.
Well, I think that's why we find it more now. So part of the reason I think we identify RSV more in adults now is because we now have, most commercial labs have access to what we call multiplex PCR panels. So we may be able to test for 10, 15, 20 respiratory viruses at a time. Those tests have really become more common over the last few years. So I think for one, we're just identifying RSV more often, that adults may have had it but just weren't diagnosed specifically with that in the past. The other thing I'll say is that COVID-19 has really altered what we consider normal epidemiology of respiratory viruses. So we have seen, for instance, last summer, there were respiratory viruses circulating pretty readily. Because we had a generation of kids who had not been exposed to respiratory viruses because of quarantine and masking and things like that. So it's really up in the air, and I think it's so unpredictable right now as to kind of what a normal respiratory virus season is because of the impact of COVID.
Yeah, it's been different. And we think in adults, RSV can be very dangerous for young babies and children. We think mostly of a cause of common colds in adults, but I mean, again, probably because we tested for it more, but I saw some people more sick with RSV, pneumonia-like syndrome in adulthood last year too.
We definitely can. I think in older adults who, again, they've sort of lost some of that protective immunity, and for sure in adults who are on medications that suppress their immune system, RSV is a bigger risk for them.
What did we see in our region for influenza this year? We know that last year it was almost non-existent. This year was different. Was it a typical year? Was it still less than normal?
We did. It was still a little lower than normal. We had quite an uptick in January. I think I didn't refresh my memory on where the peak was, but as I recall, it was earlier in the winter months. It was in January where we saw a pretty significant uptick in influenza. But overall, it was still lower this year than other years, which I think is related to COVID precautions, because we masking and social and physical distancing and all those things we were doing to prevent COVID also prevent flu.
Yeah, and there's still a trickle of influenza. We're seeing small numbers, but not high numbers right now. We had a viewer from Scotland wondering if international visitors to the U.S. are required to get vaccinated for various infections. Are there any places in the U.S. that have those infections that wouldn't be on the childhood vaccination list, or that would be atypical?
We don't have any entry requirements just for short-term travelers. That's different for immigrants and refugees that often have to go through an immigrant or refugee health exam, where they are looking at their vaccination against measles, mumps, rubella, those childhood illnesses, to make sure they're vaccinated before they permanently reside in the U.S. But as far as visiting the U.S., I'm not aware of anything that's required.
Yeah, most of those travel vaccines are, again, those sort of equator near illnesses that we're talking about.
Really more tropical countries, and it tends to be countries that may have less developed sewage systems and water supplies, where there's a greater risk of getting food and waterborne illnesses.
Yeah, okay. Can we talk about how the concept of public health got started? What's the role of the CDC, and how does each state connect to the CDC. So does every state have a Department of Health and that kind of thing?
Yeah, that's a good question.
Yeah, we're all thinking about that a lot more now than we were 3 years ago, right?
Highlighted by COVID is just shown us how important our public health colleagues are, and public health is very much a standalone science outside of medicine, that it is a mix of basic sciences, infectious disease, and epidemiology, but just as much communication and education. It really brings all those things together. And so we've all seen how incredibly important it is through the pandemic. So each state does have a state health department, and so has jurisdiction over monitoring diseases in their state. For instance, tuberculosis is a reportable disease in South Dakota. So anytime we diagnose TB, the state is aware of that diagnosis for tracking purposes. And so each state maintains a list of what's reportable. They're tracking the epidemiology in their state. They're doing educational campaigns and diagnostic campaigns. If there are outbreaks of diseases, we've had outbreaks in the Midwest of pertussis or whooping cough in recent years. We've had outbreaks of measles. The state health department kind of swoops in and helps try to intervene before those become more widespread problems. So all of the state health departments through the U.S. do cooperate with the CDC. So very collaborative relationships, sharing information back and forth and helping with disease investigations. If a state health department needs more expertise, the CDC will send representatives to a specific state to help out with an epidemic, that kind of thing.
Yeah, good. How many of us have had our labs drawn in the hospital just to see the phlebotomist disappear out the door with tubes of our blood? Where exactly does it go, and what does this place look like? We reveal that mystery tonight as Brookings Health System Lab Manager Deb Thomas takes us on a whirlwind tour of a hospital lab.
This is our new analyzer, our OrthoVitris 7600. So various testing that we can do on here is like our general chemistry testing. Some of the new testing we'll be able to do for infectious disease especially is our hepatitis. HIV we'll be able to do on here as well. We can do everything from cardiacs to thyroid panels, hepatic panels. We'll be able to do like a hep-acute panel. So if you're having abdominal pain, the doctors will be able to test that to see. And that's something that we're bringing in-house probably within the next couple weeks that we haven't been able to do before. So we are up and running as of 2 days. So it's very exciting to have that on hand. So next we are going to go over here. These are our COVID analyzers that we have. We have 3 of them. So we are able to test for COVID, PCR, and so that makes it a 10-minute test, so that makes it very nice for our patients and surgical. Next, we have our hematology analyzer here. From here, we're able to tell if we draw blood, if you have an infection, and we can tell with your white blood cell count. If it's elevated, that can tell the doctors then that you have an infection, and then they can treat you appropriately. Over here we have our coag analyzer, and this will tell you like if you're on a blood thinner, how thin your blood is. We will be getting a new one, and the exciting thing about that is we'll be able to test for those patients who are on Eliquis, which is a new kind of a newer blood thinner. We haven't been able to do that with this, so now we have a therapeutic range for those patients as well. So that's very exciting for us as well. Over here we have all of our blood that we have stored. We do have 44 units on hand at one time, so should a patient need blood due to chemotherapy or they're anemic, we are able to do that for you here at the hospital. We also have our blood culture analyzer here, which does hold different bottles of blood that you can see. All this information here can tell you if you are septic, if you have some kind of bacteria or something in your blood. We're able to tell that from here. That incubates it, and then we're able to tell if you have any kind of bacteria in your blood. This analyzer is one of our newer analyzers, and this is going to be able to do GC chlamydia testing as well as PCR for group P testing. That'll be very nice for the OB staff because then we won't miss any groupies that the culture may have missed. It's much more sensitive, so it'll be much nicer for the patients in OB. We have our blood gas analyzer. This is used to tell how your oxygen level is. You got used a lot for our COVID patients that had a hard time breathing, so we're able to tell what your oxygen, your carbon dioxide level is, and everything from here. Next, we have our urinalysis area. So if you have a urinary tract infection and you may become septic if it goes on too long, we're able to look at it, tell the doctors, they are able then to report that and give you your antibiotic that you need. This is one of our newer analyzers too. This will be able to do syphilis testing. So that is done on like new moms, OBs will be able to do it for our ER patients. And so then our syphilis testing can be done in-house, which will be new for us. Okay, go back to micro. Here we have our hood where we're setting up, we use it for setting up various cultures, from urine cultures to our blood cultures, or anaerobic, aerobic, fungal. We do a variety. We do not do like tuberculosis, AFB cultures. We don't do those here. Those are send out. We have our various incubators. And should something grow on one of those cultures, we have our Phoenix, and that is able to give ID and sensitivity for those antibiotics. So we have our little tray. We put some of the bacteria in each of these trays. One side of it will ID, the other side will give the susceptibility to the antibiotics. So then that can go to the provider and they can put you on the correct antibiotic.
Thank you, Deb, for that. Our unsung heroes in the lab. We we need them to take care of patients every day. So the last thing she talked about was these cultures and sensitivities. So you use these all the time. They're hugely important to the decision making that you have. So how do we get a culture of various types of infections, and what does that report look like? How does it help you?
Sure. So that probably is the cornerstone of what we do in infectious disease. I'll say most specialties use them. Mm-hmm. So a lab goes to the culture, a culture goes to the lab, whether it's a body fluid like blood, if an abscess has been drained, urine, and the lab, depending on the specimen it's coming from, is going to set up a culture wherein they will incubate at body temperature to try to grow whatever that bacterium is. And from there, once they grow up the bacterium and they've identified it, then as she pointed out, they can run that through a variety of different types of machines. There's several different mechanisms for how it can be done. But ultimately what we get a report out is the antibiotics to which that bacterium is susceptible or resistant, and that's what drives our treatment decisions. Yeah.
And so when I see, for example, a urine culture, I get to learn what specific type of bacteria grew and what, sometimes it'll say this antibiotic, it was sensitive, but this, it was resistant, and that actually helps us make decisions about what the best thing is to do. And some are more complex than that.
And I would say too, probably the thing to point out for that, and I always tell patients this because we so are used to having this immediate answer.
Yes.
And so this takes time. And even with a lot of rapid diagnostics in the lab, it may take 3 or 4 days to grow up and identify a bacterium and then to do the antibiotic susceptibility. So I always warn patients when I'm seeing them, like, I'm not going to have an immediate answer on this. I'm going to call you in 2 or 3 or 4 days, and we'll do something in the meantime, but we may need to make adjustments once we have that information back.
Right, good. We had a little conversation about public health before that roll in, and one disease that we have seen an outbreak of that I think has been in the news is syphilis in South Dakota. And this has been, we've heard about this at other places in the country, but remind us about syphilis, and why do you think that we are seeing this surge in cases?
Yeah, that's a great question. So I think it's really important to talk about it. I don't think we talk about sexually transmitted infections near enough. They can be a difficult, uncomfortable topic to talk about, but we need to talk about them because in South Dakota, we've had a huge rise in our rates of syphilis, but also gonorrhea along with that, particularly through COVID. And I think there was already a trend upward, but I think that was exacerbated by COVID because people just didn't have access to screening, or they were trying to stay out of the healthcare facility, so they might have been more reluctant to go in with a symptom that would point a provider to diagnosing syphilis or gonorrhea. And so it's really important that people who have risk factors, so they have multiple sexual partners, they have unprotected sexual contact, things that raise those rates, that they're having those open, honest conversations with their provider, that you have a trusted provider who you can open up to and they can recommend the appropriate screening for those things. It's really important.
Yeah. Is there a certain population or age group that we've seen more with the syphilis outbreak? Or
we tend to see sexually transmitted infections in general more in younger people. But there has been a pretty dramatic rise in older people, and partly I think people who they are older and they're not thinking about that. education around STIs is targeted at younger people. They're getting it in school, and I think older people may tend to forget, like they're at risk too. And so we have seen an increase in STIs in people over 65, and that can include bacterial infections like syphilis and gonorrhea, but it also includes HIV infection. And so no matter your age, if you're having unprotected sex, you have multiple partners, you're having sexual contact with people who have other STI risk factors, it's really important to be asking for that screening and talking to your provider about it.
Yeah, and a patient to me doesn't have to say much more than I'm worried about it, and by all means we're going to test them.
100%.
There's not really a downside to screening, and I think some people have some fear about this, but really for most people it's a urine sample and a blood sample to do these screenings.
That's important to point out, and I think for sure they get a bad rap for screening because people think there's going to be an uncomfortable swab done, as an example. And for the most part, they are urine and blood tests. If people have risk factors for other locations having STIs, there may be a swab involved, but providers are going to talk through that with everybody. And so that's just a really important thing for us to recognize, that the rates of STIs in South Dakota are no different than anywhere else in the country, where it may be talked about a little bit more.
Yeah. Good. We have a couple more questions. We had a caller from Webster ask us to discuss infection prevention for people with diabetes. So I guess this could mean a lot of things, but maybe we start with the feet. That's sort of the classic place that we think of people with diabetes getting infections.
Sure, that's a great question. I think there are lots of facets to talk about there. So really, people living with diabetes need to be monitoring their feet very closely. I'm telling my patients who have had diabetic foot infections before, in particular, be looking at your feet every day. Or if you're unable to look at your feet every day, make sure you're having somebody, a spouse, a family member, look at your feet if it's at all possible, to make sure that you have appropriately fitted shoes, that your shoes aren't rubbing and causing blisters or calluses that can get secondarily infected. And then controlling your blood sugars and working with your provider, because bacteria love high sugars. That's how they thrive. And so keeping your blood sugars under control is a really important step to preventing infection.
Yeah. What else is it about diabetes that sets people up for some of these foot infections, aside from the high blood sugars?
Great question. So a lot of times people living with diabetes also have neuropathy. They have impaired sensation in their feet in particular. And so you may not feel that your shoe is rubbing, or you may not feel that you're walking differently on your foot, and that can lead to bony changes, it can lead to calluses, and then those become infected. And particularly, I think the common story I hear is I didn't feel anything on the bottom of my foot, and I wasn't looking, and by the time I recognized that there was something wrong, it was a very severe infection. And so that's why that visual inspection of your feet on a regular basis is so critical.
Yeah. And those foot infections range from a skin infection, which is why a person would want to be very mindful and looking for stuff, to the worst case scenario, which is a bone infection, which sometimes results in amputation, right?
Right. People living with diabetes also, along with the neuropathy, may have impaired circulation, peripheral vascular disease. And so if the blood flow is not getting there, it's harder to heal a wound. It's harder to get the antibiotics to that area. And so there are situations wherein if an infection is let to progress too long, that it gets down into the bone, where in an adult, there's not a great blood supply to bone. And so at that point, really the best option is amputation and trying to preserve the healthy tissue that's left behind.
Yeah, good. Aside from those foot infections, what other types of infections are diabetics more likely to get than someone who doesn't have diabetes?
I think really in large part it depends on blood sugar control. Because if your blood sugar is really well controlled, your risk of infection is not hugely different from the general population. But with high sugars, we think about urinary tract infections in particular. We think about skin and soft tissue infections. So those are probably the biggest things I would think about, just because, again, bacteria thrive in that high sugar environment. And when we think about infection prevention in folks with diabetes, we need to be thinking about vaccines as well. So making sure that people living with diabetes have had their pneumonia vaccines, who have had their hepatitis B vaccine, because we know that the lancets that people are using to prick their fingers for blood sugar checks, that blood exposure increases the risk of transmission of hepatitis B. And so that's now a routine vaccine recommended.
Okay. This is a great question. So the first is, which illnesses can be prevented with vaccines? That might be a list that's a little bit long for us to tackle, but they then asked, do you see any changes coming in terms of childhood vaccinations in the U.S.? It seems the list continues to grow, but is there potential for any vaccines to go away, like if a disease is eradicated? Which, I mean, for example, polio. I think that's a very interesting question. I mean, we don't vaccinate against smallpox anymore. So what would it take for us to not vaccinate against polio?
Right, that's a good question.
Yeah.
So there has been a very intensive effort to eradicate polio that has been hampered by geopolitical issues in different times. So there still are wild type polio cases, particularly in parts of Southeast Asia. We think about Pakistan has had issues, Afghanistan have had issues, and they're issues that are fortunately associated with poverty and war-torn regions of the world, and so that greatly hampers public health efforts. And so polio is probably the best example of something where we have so markedly reduced worldwide.
We're so close.
We're close to eradication. You could potentially see that vaccine being unnecessary in the future. I think for the others, it's hard to predict because, again, we have parts of the world that are really disadvantaged as far as getting vaccines. And so it's hard to stamp out measles, mumps, rubella when you can't routinely deliver those vaccines to all of our populations.
Yeah. So probably not anytime soon.
Probably not. I don't anticipate it.
Yeah. Okay. What is the best age to receive the shingles vaccine? You mentioned this earlier.
Yes, so it's routinely recommended for the general population over age 50. For people under age 50, there are some specific medical conditions for which shingles vaccine is indicated. So basically, comorbidities that would increase your risk of shingles, so immune compromising conditions basically. But it is recommended for everybody over 50. It's a 2-dose series, so it's pretty easy to do. People do tend to have some more side effects compared to other vaccines. What I tell my patients is if you feel a little flu-like after your vaccine, that's your immune system revving up, doing what it's supposed to do, and that can happen a little more frequently with shingles vaccine compared to some of the others.
Yeah, but not any reason to wait long after 50. I mean, I wouldn't advise someone to wait till you're 60 or anything like that.
Not at all.
As far as we know, the immunity is very long lasting with these vaccines.
Long lasting, very good protection against shingles with our current vaccine.
Good. A Mobridge viewer wants to know what infections keep us from donating blood. So what restrictions are there on donating blood if as far as infectious diseases?
Good question. So any blood-borne infection, so we think about hepatitis B, hepatitis C, or chronic viral infections that would preclude donating blood. HIV would be another one that can be transmitted. They're screening for a variety of other infections when you donate blood. So there are some less common viruses, things like HTLV would be a good example, where the vast majority of the U.S. population has never been exposed to it, but they're screening for those after blood has been donated. So they are looking for a whole variety of pathogens that somebody may not know they've been exposed to. But the big ones that people would know about having would be hepatitis B and C and HIV that would preclude donation.
Good. We have a person living with quadriplegia at increased risk of infection. Please discuss methods to prevent infection in this population. So what unique risks does someone with quadriplegia have?
Sure. So the thing probably that comes to mind right off the bat is just that immobility increases the risk of pressure-related injuries. And so when someone isn't turning regularly, they're not repositioning, then we need to think about, are there going to be sores that develop that then get secondarily infected? That's probably the most common thing. We see a lot of urinary tract infections in people that have quadriplegia just because they are draining their bladder differently. They may not be urinating spontaneously, and that increases the risk for UTIs.
Got it. When it comes to UTIs, another hot topic is what we call asymptomatic bacteria. So, for example, in the nursing home, I see a lot of urine infections get run for pretty nonspecific symptoms, and they grow bacteria, but they're not always infections. What's the difference between having bacteria and not having infection? We've got 20 seconds.
Great question. So people used to think the bladder was sterile. It is not. It has its own microbiome, and having bacteria in there does not mean you have an infection. And so we have to correlate the symptoms with the culture. And if someone doesn't have symptoms, we don't treat for UTI.
Good. All right. The winner of our drawing tonight is Geneva from Scotland. Thank you, Geneva, for asking a question during the first 20 minutes of the show. A gift will be sent to you. We'll be back after this.
I didn't always know I was doing this, but I spent my entire professional life doing research for this book.
And And here's one of my favorite things about this book. I mean, we're focusing on end of life, but really, you could read this when you're 18 and learn. You would learn a whole lot, not only about how to take care of the elders in your life, but how to take care of yourself. You've given us so much, even in this last hour.
Thank you.
And certainly in this book. So I just want to say thank you on behalf of all of us, your readers, your listeners, your viewers.
Life expectancy is a measure commonly considered when it comes to the overall health of a population. In this day and age, when most of us think about which medical interventions are most important to increase life expectancy, we probably think about things like treatment of cancer, interventions to treat heart attacks, or surgeries for life-threatening illnesses. While those things are all important, their overall impact on a population's life expectancy pales in comparison to the prevention of infectious disease. Average life expectancy around the world has doubled in the last 200 years, from about 40 years to 80 years, with the bulk of that change occurring long before we had effective cancer treatment or cardiac catheterization. Before the 20th century, infant and childhood death was extremely common due to infections spread by contaminated water and food. It is estimated that through most of human history, nearly half of children died before adulthood, almost entirely due to infections. Armed with the new knowledge of germ theory, societies in the late 1800s began instituting early public health interventions, such as sewage management, water treatment, milk pasteurization, and garbage collection, which resulted in rapid decreases in death from food and waterborne infections, and thus increased population-wide life expectancy. Later, widespread use of vaccines for many fatal diseases led to enormous improvements in the health and longevity of populations across the globe. Try to imagine a world in which almost everyone is affected by the death of children due to polio, measles, smallpox, tetanus, the list goes on. That these deaths are now extremely rare or eliminated altogether is nothing short of a modern miracle, and we ought not take it for granted. Antibiotic use has exploded since the discovery of penicillin in 1928, and the proper use of antibiotics continues to help us prevent early death due to infections that might have been fatal left untreated. Modern science has led to effective treatments for even the most challenging infections, such as tuberculosis and HIV. Modern medicine uses abundant, wonderful technologies and treatments which help us extend lives and reduce suffering of our individual patients. But statistically, no fancy new development is likely to have the quantitative impact on human society that compares to those early public health measures. As a society, we would be careless to forget the worth of our public health institutions, which have helped us thrive and double our average life expectancy. For volunteering her time to help us learn more about infectious diseases. If you would like to see and hear more episodes of this program, please like and follow us on Facebook and YouTube, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper, and be sure to look for the podcast of this program, Prairie Doc On Call, wherever you get your podcasts. From all of us here at On Call with the Prairie Doc, as we celebrate our 20th season of truthful, tested, and timely medical information. Until next time, stay healthy out there, people.
evidence for human consumption of cannabis as a drug has been discovered in a 2,500-year-old cemetery in Central Asia. We're still debating its value today. Medical cannabis, next time on Call with the Prairie Doc, celebrating our 20th season.
Hello, my name is Dr. Ken Bartholomew from Pierre, and I serve on the Healing Words Foundation Board. This year we celebrate the 20th season of the Prairie Doc, created by my friend, the late Dr. Rick Holm. I watched as the Prairie Doc TV, radio, and newspaper programs were created, and now I watch as the legacy continues. Countless professionals donate their time to bring timely, trusted, truthful medical information free to the public without advertising, spin, or bias. As a native of Lemon, South Dakota, I realize how important this is, particularly to people in rural areas. You can help sustain the work of the Prairie Doc. Truthful, tested, timely information for 20 seasons. Please consider a charitable gift to the Healing Words Foundation, a 501c3 corporation. Go to prairiedot.org and donate today. And thank you.
Major funding for On Call with the Prairie Doc has been provided by Avera is a proud sponsor of On Call with the Prairie Doc on South Dakota Public Broadcasting. Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, Ophthalmology Limited, South Dakota Academy of Family Physicians, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Vance Thompson Vision, Monument Health, Black Hills Medical Society, Brookings Madison Flandreau District Medical Society, Pierre District Medical Society, Yankton District Medical Society, Orthopedic Institute, Lake Poncet Sailing Academy, Aberdeen Asthma and Allergy, Dakota Bank, South Dakota American College of Physicians, and Swiftel Communications.